Module 2, Auditory Assessment and Hearing Disorders. Okay, continuing on with your required readings, your major concepts, and now auditory function. So I hope this is all review for you from health assessment. So here we have a picture of our sound path to the brain. So our sound enters the ear, external ear. It goes through the auditory canal up to the tympanic membrane. The vibration of sound vibrates these little ossicle bones here, the malleus, incus, and stapes. And then we have our oval window where then these messages are sent to our semicircular canals where it is converted into neurological message through the bony labyrinth up the cranial nerve 8 to our brain for processing. Okay, so anything can happen along the way, and that's what we're going to talk about next. Assessment of our audio system. So we're going to get a detailed patient history before the physical examination. And during the assessment, it's important that we listen and ask questions about the patient's medical history, family history, any medications the patient is taking, because that can affect hearing. We want to also pay attention to the patient's posture and facial expressions, because that can actually give you clues that the patient is having difficulty hearing. We also want to have an idea of the patient's hygiene. So how do they clean their ears? Do they use those cotton tip swabs or Q-tips, inside the ear? Because that could actually injure the ear. It can push foreign objects into the ear canal. It can also cause impaction of cerumen, which is earwax. So those are all important things to ask a patient. Now, if we look at this picture, we see the otoscope. So that's used to look inside the external ear canal. And it can see all the way up to the eardrum or tympanic membrane, same thing. So if we inserted this into the ear, this is what you would see down here. This is a healthy looking tympanic membrane. It is pink, it is translucent, it's kind of pearly, there's some grayish tones in there. That is a healthy looking tympanic membrane. So you should definitely know what normal looks like. This picture here on the left is a Q-tip penetrating through the tympanic membrane. And then if you see in this picture, this is a tear, a hole in the tympanic membrane, which we want to avoid. Assessment of the audio system. So when we're assessing this system, we're looking at both hearing and equilibrium, also known as balance. So the word vestibular also means balance. So two terms that you should know, vertigo and nystagmus. So vertigo is a sense that a person or objects around the person are moving or spinning, and it's usually stimulated by head movement. Not all the time, but usually by head movement. So this isn't to be confused with dizziness. So dizziness is a sensation of being off balance. Okay, so there is a difference, and sometimes those words are used interchangeably by patients, but you kind of want to prompt them to really get, if it truly is a vertigo sensation they're feeling. Then we have nystagmus. So nystagmus is abnormal eye movements or blurred vision with head or eye movement. And it's seen as twitching of the eyeball, or it's described as blurring of vision with head or eye movement. So the patient may describe it like that, or you can assess the patient with this twitching of the eyes. So you can see in this video here.
Gentamicin to the left ear. He had a 35% weakness prior to his injections, and he, as you can see, has right beating nystagmus.
Okay, so that eye twitching is nystagmus.
Indicative.
All right, so diagnostic studies. So when we assess for vision problems, we're always going to do a visual acuity test. When a patient comes in with a hearing problem or ear pain, then we will do a hearing acuity screening. So this is pictured here. So the patient wears, headphones, and there's some type of device Not all devices look like this, but they're very similar, and then the patient just indicates where he or she hears the sound. Then it makes this chart here. You as the RN do not need to know how to interpret this. And then it will give useful information about the degree and type of hearing loss, the tones, and all that. So very important. Noise levels. So this is a picture of common sounds and their decibels. So this is 0 to 160 decibels. Here at 70 is when prolonged sound at this level can cause ear damage. And then any sound at this level of 120 can cause permanent irreversible ear damage, hearing loss. So that means that we want to protect our patients and let them know this information. Ototoxic medications. So the ear has many little structures in there. It's a sensitive organ, and it has a lot of fragile parts. So there are several categories of medications that can be dangerous to the functioning of the ear. We call those ototoxic medications. A lot of times patients don't even know that some of the medications that they're taking can be ototoxic. So it's important that we recognize that when we're looking and asking about their medication use. So commonly are going to be some antibiotics, some diuretics, NSAIDs, and some chemo drugs. So we're not going to go into them specifically right now, but just know there are ototoxic medications you need to be aware of. So signs that the patient may be experiencing ototoxicity will include tinnitus, which is ringing in the ears, diminished hearing, and changes in balance. So we want to protect our hearing and all the structures inside the ear. So health promotion. When a patient's going to be exposed, or anyone is going to be exposed to high levels of noise, they should protect their ears by using, ear protection like earmuffs here, or when they're at work, the employer should actually provide ear protection. So you want to avoid continued exposure to any noise higher than 70 decibels. And important to note that hearing loss caused by noise is not reversible, okay? Not reversible. Okay, now we're going to jump into our hearing disorders. Risk factors of hearing loss, and we're talking about just general hearing loss. Advanced aging, so hearing loss is part of age-related changes that we can expect. Repeated infections of the ear, occupation, ototoxic medications, ear trauma, tumors of the ear, continuous exposure to loud noises, and genetics. So all of those things can lead to hearing loss. So specific age-related changes. So cilia in the ear can now become stiff, stiffening of the tympanic membrane. Those little 3 bones in our ears become calcified, and we have presbycusis. This leads to presbycusis, which is a term for age-related hearing loss. So remember that prefix presby means age-related. So important to know that hearing loss that is age-related is sensory neural hearing loss. So sensory neural hearing loss. So how do we communicate with someone who is hearing impaired? Really important to know this, because in practice, actually 1/3 of Americans between the ages of 65 to 75 have some degree of hearing loss. So you're going to encounter somebody in your life, if you haven't already, who can't hear very well. So you want to face the patient directly when speaking to them, okay? So they can kind of read your lips. It helps. And you want to speak slowly and be attentive to enunciation. So that means speak slowly and pronounce, all parts of the words. You want to lower the pitch of your voice, because when you have certain types of hearing loss, you lose the ability to process high pitch tones. So the higher frequency tones, when you talk, like if you're talking, can you hear me? Like that, then they're not going to be able to hear you. So it's better to lower the pitch of your tone, speak slowly, and face the patient, and do not yell at them. That is not going to help. It makes it actually more difficult to understand the words, and then the patient may feel embarrassed that you're yelling at them. We have 3 types of hearing loss. We categorize them into conductive, sensory neural, and mixed. So conductive hearing refers to some type of obstruction of the sound transmission. So there's something in the external ear, in the ear canal, that is blocking the sound to the rest of the ear. Okay, conductive. Then we have sensorineural. So this is when there is a deficit present in the cochlea, cranial nerve, or the brain. So neural. Okay, so the nerves, the neurons are involved. Then we have mixed. So it can be a mix of those two that we just talked about. So clinical manifestations of hearing loss. So when somebody is not able to hear that well, they may not always call their doctor and make an appointment to see what's wrong. You know, people don't like to go to the doctor. They don't like to, you know, admit that they may have something going on. So human beings, we try to compensate. So maybe you'll learn how to read lips and you'll kind of rely on that until you can't anymore. Maybe you'll turn up the volume really loud to the radio, to the TV. You're frequently asking, what did you say? Oh, can you say that again? Or maybe you'll just withdraw from conversations because you know you're not going to be able to hear the whole thing and you don't want to be put into a position where you have to answer a question and you couldn't hear. Or sometimes it will affect the patient's speech and you'll notice, you know, they're not able to hear themselves, so their speech is affected. And then sometimes they get into arguments with their spouse or other family members because they don't understand, or they can't verbalize that they're having a hearing problem. Diagnosing hearing loss. So we want to get a good history on the patient. We want to use an otoscope to look inside the ear to see if there's any structural changes that we can see and visualize. We want to do a hearing test to see if there's anything that we can see on that end. And once you determine what the problem is, then we can treat it. So the patient may need T-tubes or tympanostomy tubes like seen in this picture. Sometimes there's fluid buildup and that can cause hearing issues or pain. Very common in kids, recurrent ear infections, so they may need a tube inserted. Hearing aids can be an option if the patient just needs amplification, just louder, but hearing aids don't help to hear better, just louder. With our assessment, we're going to take vital signs, of course. We're going to look inside the ear to see if we see anything, take a look at those diagnostic testing. And then remember, for age-related, that patients over the age of 60, we expect them to have some degree of sensorineural hearing loss, which is also known as presbycusis. So teaching. So if the patient is having an ear procedure, we're going to give them both pre and post-op instructions. So after the patient has their procedure, the patient should be flat and turned on the side with the operative side facing up after a tympanoplasty. This will decrease the chance of packing being displaced. So if a patient has a tympanoplasty, there will be some dressing inside the ear, so we want that dressing up. We want to make sure that the patient follows up to have their hearing checked to make sure that everything is going okay. And we want patients to increase their fluid intake. This will actually help with that dried cerumen impacting hearing. In the older patients who have really dry earwax, if you increase the fluid intake, that can help decrease that thickening of the earwax. And then we want to teach the patient signs and symptoms of infection so that they can seek treatment early. We want to make sure they have noise protection, and they should avoid to use cotton swabs or anything else to remove the earwax or to clean their ears. If the patient has a true hearing loss, there is a lot of technology these days that can help them live a normal life. So that's also something that we want to provide resources. Here in this picture, you see the example of a cochlear implant. So cochlear implants are not for everyone. I just wanted to show you an example of this. I'm not going to talk about it, but just so you know, they do exist. Next, we're going to talk about external otitis. So we're talking about the ear that you can see just looking at the ear, the auricle, all the way down to the tympanic membrane. That is the external ear. So external otitis is inflammation or infection of any structure from the outside of the ear up until the tympanic membrane. So this is usually caused by excessive water exposure, decrease in cerumen, drying of that canal and any type of skin breakdown that can lead, an organism to enter. So external otitis can be termed swimmer's ear. Often people who swim in the ocean or swim in pools a lot will develop this. So if there's a lot of standing water in your ears after you swim, that can lead, to harbor bacteria, and it can lead to an infection. Also, chlorine in pools can kill the normal flora in your ear, and then that can also lead to infection. So the pictures on your left here, you can see, and this is using an otoscope, this ear is nice and healthy, and then this ear canal is inflamed. It's pink, it's red, it's edematous, it looks like there's some drainage, so that is an unhappy ear canal. And then here again, because anything on the outside of the ear is still external otitis if there's an infection. So you can see different types. External otitis can be caused by bacteria, fungus, or virus. So risk factors for this include recent trauma to the ear, warm and high humidity climates, history of a lot of swimming, history of hearing aid use, and piercing. So all of those things can lead to external ear infection. Signs and symptoms are going to include edema, pain, erythema, and drainage. Those are all signs of inflammation. If you have edema in your ear canal, that can cause muffled hearing. So patients may say, I can't hear out of my right ear. The drainage that comes out could be clear, or it could be purulent. If it's purulent, then we know that it is infectious. The way we're going to diagnose this is by looking at their history, looking inside the ear canal, and possibly culturing that purulent exudate. We're going to check the vital signs and look at all those signs and symptoms. When it comes to age, adults and children are both affected by external otitis. Children may have a higher prevalence only because they tend to do more water-related activities than adults, but any age can get it. Treatment, we want to keep that ear clean and dry, and we want to treat infection and inflammation, so that by giving those medicated eardrops. For interventions, we can do comfort measures. Dry, warm heat can provide comfort. It also increases circulation. When it comes to positioning, the patient should be positioned with the affected ear on a soft object like a pillow, because that can also be soothing and it can facilitate drainage. We want to tell the patient to finish their course of antibiotics and to follow up with their provider. Next is otitis media. So this is infection of the middle ear. So we're talking about this green circle right here. And the pathophys on this is inflammation and secretions cause obstruction of the eustachian tube. So this tube right here is the eustachian tube. It's a narrow tube that links the nasopharynx to the middle ear. Normally it's closed and it only opens when we swallow, yawn, or chew. So there are risk factors, so anatomical risk factors. So in children, the eustachian tube is flatter, and that leads them higher risk for infection. If the patient already has an upper respiratory infection, because again, the nasopharynx is connected to this eustachian tube, so that can lead to infection here. Seasonal allergies. So if anything that causes inflammation in this tube will cause this tube not to open anymore, and everything in here gets trapped. So fluid, bacteria, pressure starts to build, and pain and unable to hear because it's blocking the sound. That is otitis media. Signs and symptoms are going to include ear pain. If it's a small child or nonverbal, they'll often tug or pull at the ears, have trouble sleeping, or lying flat. Fever typically accompanies otitis media. Patients can experience effusion, which is fluid buildup behind the tympanic membrane in the middle ear. And that fluid can be either bloody drainage or purulent drainage or serous drainage. Hearing loss as a result of that edema and fluid buildup. And babies will refuse to feed, and just an overall feeling of not feeling well, aka malaise. So to diagnose this, we're going to look inside the ear and get a good history. There are some surgical procedures that can be done depending on what the problem is. So if there's like continuous fluid buildup, they can do a tympanocentesis where they aspirate fluid to relieve the pressure. They can do a laryngotomy or tympanostomy. This involves making a hole in the tympanic membrane for drainage, or putting a tube, like seen in this picture, to drain fluid. So it just depends what the cause is. So these patients will have antibiotics, and they can also be given over-the-counter pain medications for either fever or pain. We want to instruct them to avoid getting their ear canal wet, because that can exacerbate the risk of infection and also increase the pressure in their ear and increase the pain. So they should follow up with the doctor just to make sure that the infection has cleared. It can be really painful, this type of infection, but if they follow doctor's orders about positioning and taking their meds, then this usually clears up pretty fast. Moving on to tinnitus. So tinnitus is often described as a ringing in one or both ears. It doesn't necessarily have to be a ringing. It can be any noise that nobody else hears but you. And it's usually, when you hear it, it's very loud. It's taking over all the sounds around you. So for example, if you've ever gone to a concert and you were listening to really loud music for hours, you come home and you're trying to go to sleep and you can still hear like a hum, a really loud hum. That is tinnitus. So that would be temporary tinnitus, but repeating or repetitive loud noises can lead to a permanent tinnitus. All right, so risk factors: advanced age. So if you're older than 60 with that neurosensory hearing loss, that can also lead to tinnitus. Exposure to loud noises, I just talked about that. Earwax blockage, so if you have cerumen, which is earwax that gets compacted into your ear, or maybe you push it in unknowingly with a Q-tip, that can lead to tinnitus. Genetics, so certain conditions, like for example, otosclerosis, it causes stiffening of some of the middle ear bones, that can lead to tinnitus. And then medications, so we're talking about side effects and ototoxic medications. So many prescription and over-the-counter medications increase the risk of tinnitus. So salicylates, NSAIDs, some antihypertensive meds, chemo medications, they can have a side effect of tinnitus. So just a reminder, we don't consider tinnitus a disease process. More so, it is a clinical manifestation. Okay, so it's a symptom, it's not a disease. When it comes to treatment for tinnitus, it's really going to depend on the cause. And all of these medications listed here, we have like Xanax, antihistamines, anticonvulsants, gabapentin. So these medications, it really just depends. And also it's kind of like a trial and error to see what works and what doesn't work. But if a patient is taking an ototoxic medication, or one of the medication side effects is tinnitus, then they'll most likely stop that medication. To determine what is causing this, we can have them do a diary and tell them to write down when they experienced the tinnitus, what they were doing, when it stopped, all the details, so we can try to pinpoint what's causing it. And I really like this picture from your textbook. It kind of shows what the pathophys of tinnitus and how it can be associated with the structural changes in your auditory system. So tinnitus can be caused by impacted earwax, otosclerosis, and so on, things that we just talked about. Moving on to vertigo. So we mentioned vertigo a little bit earlier. Let's go over it one more time. So this is a result of abnormalities in the semicircular canals or the central nervous system that cause a spinning sensation. So we're going to talk about these semicircular canals when we talk about Meniere's disease. But when we see central nervous system, this is our brain. So the brain can cause vertigo, or it can be these semicircular canals. So the result is going to be a feeling of spinning and dizziness. There are a lot of risk factors, and sometimes we don't know what's causing it. So certain medications can cause it, a brain injury, a upper respiratory tract viral infection, if you had a cerebrovascular disease, if you're over the age of 60, if you have a family history. So there's a lot of risk factors for vertigo. So signs and symptoms of vertigo. So patients will experience a feeling of spinning at rest. So they're at rest, but they feel like they're spinning. They're going to have imbalance, lightheadedness, nausea, vomiting, and hearing loss. This all kind of leads to a safety issue. So patients in the hospital, you really have to remember that you need to teach them to sit up, dangle, change position slowly, use the call light when you want to get out of bed so you can walk with them. They shouldn't be walking alone in any hallways. They should be in a low stimulus environment. So to diagnosis is going to be a comprehensive history. So you're going to ask a lot of questions. We're going to take their vital signs. We're going to assess their balance. We're going to take a look at any imaging that was ordered, like a CT scan or MRI, to see if there is something going on internally related to maybe nerve conduction. Age-related changes. So increase in age has been shown in vertigo, but it can happen at any age. It really just depends on what the pathology, what is the main etiology of what's causing the vertigo. So medications. Medications are aimed at treating the underlying problem, if known, and decreasing dizziness and the other clinical manifestations, so like supportive care. There are some other teachings that we can do, like having them decrease the intake of salt, nicotine, alcohol, and artificial sweetener in the diet. They don't know why this is helpful. The rationales aren't well understood or tested or researched, but they have some educated guesses, like decreasing the salt will probably decrease vertigo based on fluid retention and blood pressure, and so on. But those are things that we educate the patient to do. They should reduce their stress. Again, it's not 100% correlated, but they feel like if you decrease your stress, it will decrease your central nervous system excitability, and then it will decrease your signs of vertigo. I don't know. That's what it says. We're not sure. Again, safety is a big deal with anyone who has vertigo, and we just want to manage the signs and symptoms and possibly decrease the frequency of these episodes. And our last topic is Meniere's disease. So this is a disorder of the inner ear that affects a patient's balance and hearing. This is because they have an accumulation of endolymph in this bony labyrinth here. So we have our bony labyrinth, aka our semicircular canals, and I'm going to describe this to you again. So this blue here is a tube, and it has endolymph inside. Here in the brown, there's also fluid in there called perilymph. So they are separate, and they're supposed to be balanced. But with Meniere's disease, there is too much endolymph. So this bulges, this blue tube bulges with endolymph, and it's going to distort information to the brain. And sometimes it bulges so much that it bursts, and then this fluid will mix with the perilymph. And during that time, all of this information, the brain thinks we're moving, we're not moving, and it results in these episodes of vertigo, tinnitus, and hearing loss, which is the triad of signs, clinical manifestations for Meniere's disease. Okay, so exact cause is not known. We don't know why it happens. It most often occurs with infection, stress, traumatic injury, and allergens. There are lots of risk factors listed here. You can read through them here. Moving on. Signs and symptoms of Meniere's disease. Again, those three main ones, vertigo, tinnitus, and unilateral hearing loss, sometimes could be bilateral. So every time they have an episode, they lose a little bit more of their hearing, and it's progressive, and there's no cure. So the treatment is aimed at treating the symptoms when they're having these episodes. So more signs and symptoms: nausea and vomiting, sweating, diarrhea, headaches, and when they have sudden movements, all of these manifestations increase. uncontrollable eye movements, abdominal pain. And these episodes come on without warning. They just happen at any time, and they can last for hours. Some patients have them once a month, some have them once a year, some have them weekly. There's no pattern to them. So this can be debilitating. Again, treatment is going to be symptomatic relief. There are some surgical procedures that can be done under severe cases where, try to make that endolymph drain. We can inject ototoxic medications into this middle ear here to try to have that ototoxic medication kind of impair the ear, but that can lead to hearing loss. So the patient needs to make that choice, the risk versus benefit on that. So assessments, it's going to be based on ruling out other disorders it may be, and then once they do determine Meniere's disease, then again, the treatment is just going to be aimed at symptomatic relief. These patients will have a positive Romberg's test, if you remember how to assess for that. They're going to be off balance. They'll have some diagnostic testing like an MRI and CT scan to rule out any structural abnormalities. And then we have interventions. So again, medications are going to be based on their symptoms. So if they're nauseous, we're going to give them antiemetics. We can give them motion sickness medication, which is meclizine. So again, it's the signs and symptoms that we're treating. And then because there's this buildup of endolymph, patients are also given, they can be given diuretics to kind of, pull the fluid out. Low sodium intake, because sodium likes fluid. It will decrease that fluid retention in some patients. We want to emphasize safety measures so that they don't fall or have another type of injury. So we want to make sure their rooms are not cluttered and provide them with an assistive device if needed to help with ambulation. We want to make sure we get them a consult with a specialist, either neurology or an ear specialist, so that they can have, patient-centered comprehensive care. Acupuncture is, non-traditional method of treating any diseases here, but some patients have benefited from that, so it is included in your textbook. So the takeaway from this one is there is no cure. We're treating the symptoms and safety, huge on safety. And that concludes Module 2 on ear disorders.